This is a PowerPoint presentation about ankylosing spondylitis, and it includes an audio commentary, and I've added audio to each of the slides so that you can play it in your own time. If any of you have any issues listening to this audio, or you have any questions about patients with AS, please let me know and I'm happy to go through things with you. And here are my contact details, just in case you don't have them already. Ankylosing spondylitis would come under the management of rheumatologists really, and it's part of a collection of conditions which I've listed here, which are collectively known as the spondarthropathies. That means spinal inflammatory joint diseases, and you can see here that AS is one of them. It's actually changed its name to Axial spondarthropathy now. It's only known as ankylosing spondylitis if you have X-ray changes to the skeleton. It also includes things like psoriatic arthropathy, a kind of psoriasis. You can get a juvenile form of AS. You can get a reactive arthritis or Writer's syndrome, which can occur after an infection or actually be a sexually transmitted form of arthritis. And there's also a link to bowel disorders. There's quite a strong correlation between the gut and joints. So people with ulcerative colitis or Crohn's disease can also sometimes have a very similar condition in the spine. As a disease, it's certainly been around since antiquity, and I just thought it might be interesting to show you a picture here of a skeleton from the 6th century. What you can see here is that the spine has fused from the sacrum all the way up the lumbar, thoracic and cervical spine, and there's an increased kyphosis. So this person in life would have had a completely fused or ankylosed spine. It's important to realise that ankylosing spondylitis isn't really a disc disease, although it can involve the disc. You can get what's called a discitis. But basically, ankylosing spondylitis involves bony outgrowths called syndesmophytes that actually grow upwards or downwards and join together and form what's called a bamboo spine. One of the earliest documented cases of AS in the literature is this gentleman here who died in the year 356 AD, whose skeleton was found recently, and he had the bony changes of ankylosing spondylitis. And you can see in this graphic here that he has a stooped posture and he's actually using a cross to keep him upright. One of my hobbies is Egyptology, and there is some evidence that this gentleman also had AS. This is Ramses the Great, or Ramses II, and his skeleton does show some changes which are possibly ankylosing spondylitis. First of all, we need to define what the words mean. Ankylos is Greek for bent or angled, spond means spine, arthros means joint, and pathy means the study of disease. So it's a chronic systemic inflammatory disorder that mainly affects the spine, but not only. Relatively common, it affects 0.5 to 1.5% of the population. It used to be thought that only men got the condition. Then it was thought that it was a 10 to 1 male to female ratio. Then we went to 3 to 1, and then 2 to 1, and now we seem to think that this affects women in equal numbers to men, but women tend to present differently, so it's more difficult to diagnose. One of the problems with a lot of rheumatological disorders is that the symptoms are very common: tiredness, aches and pains, muscle pains, stiffness, which most people will get at some point in their lives. But ankylosing spondylitis can be quite specific and quite easy to diagnose if you know what to look for. It's known as inflammatory back pain, so it's not degenerative. One of the key features is called enthesitis. Now the enthesis is where a ligament or a tendon inserts to a bone, and that becomes very painful in AS. You can also get organ involvement. It can involve the eyes, the skin and the bowels. There is a very strong genetic link between Hla B27, which is a gene, and the disease. It's not a complete correlation, so it's possible to have the gene but not the disease, and vice versa. But if I had a room full of 100 people and I did some genetic testing on them, probably about 12% of the people would have Hla B27 anyway in the normal population. But if I had a room with 100 people with AS that's been diagnosed, probably 95% of them would have this Hla B27 molecule. The symptoms in men tend to be low back pain, stiffness, loss of movement. Syndesmophytes are little tiny lips of bone that start to form, which I'll show you some photographs of later. It can also lead to a low bone density or osteoporosis and fractures, and obviously some real severe spinal deformities as well. The presentation tends to be different in females though. Unlike osteoarthritis, which is pretty much correlated with increasing age, AS tends to affect younger people, so the typical presentation for somebody with AS would be a young man of mid-20s or even late teens. I've put here that men are affected more than women in a ratio of 2:1, but bear in mind that these statistics are probably changing now. It does seem to be more common in women. Most people will get symptoms before the age of 30, and there are geographical differences depending upon allele frequencies in the population. And the general frequency of AS is between 0.1 and 1.4% of the population. Quite often in rheumatology we don't have a full picture of how diseases work. We are starting to get a better picture now, so it's thought that some kind of infection initiates the pathological process, which is picked up by the white blood cells, and the problem with AS is this massive influx of cytokines, a cytokine storm, which is the cause of tissue damage and inflammation. On a physical level, the problem from the physiotherapy point of view is inflammation at the site of ligament or tendon attachment to bone. So on this photograph here you can see a person's cervical spine, and you can see them facing towards the left, and you can see that the vertebrae lower down are completely fused. So if you follow down the anterior margin of the vertebral column, it should go white, black, white, black, white, black. And the white would be the bone and the black would be the disc space. But you can see here that in the lower cervical spine it's all fused into one bone. There will be no movement in this person's lower cervical spine. There is one exception, so if you look higher up there is one area of hypermobility. So this person would have had a very painful neck because all of the movements in the spine are occurring at one level. The name for this fusion of the bones is ankylosis. The signs and symptoms of ankylosing spondylitis are sometimes very common anyway, so it can be difficult to spot them. So low back pain for 3 months, radiation to the buttocks and the thighs is not unusual, but not sciatic type pain. Ankylosing spondylitis doesn't tend to affect the spinal nerves. Early morning stiffness is a real feature, and that's very typical of inflammatory disorders, in particular rheumatoid arthritis. One of the key diagnostic criteria for AS is that it's made much better with exercise. So people with AS will usually say, I can't sit still for too long, I feel much better when I move around. And also fatigue can be a major issue. And I think this can be multifactorial. I think it's partly because of the pain that's being caused, which has an impact on people's sleep and mood, and the inflammation as well. and I think there is sometimes a genuine fatigue from the blood disorder aspect of AS. Quite often chronic diseases go through a course of exacerbations and remissions. MS is a good example, and AS is no different. So one of the things that is quite exhausting for the patients is that they can have a good day followed by 3 days of severe pain or a week of severe pain, and then followed by severe tiredness afterwards, and it doesn't seem to be related to any particular activity. In males, it's very common for the sacroiliac joints to become involved early on and spread up the spine from inferior to superior. It can also cause problems with the discs and the joints between the bones at the back of the spine called the apophyseal joints. It can also affect the joints between the ribs and the spine, and it can affect the ligaments in the spine as well. If you just pause this slide, we have two pelvic X-rays here. On the left we have a normal pelvis, so we can see the pelvic girdle, the hip joints, and we can see a fairly clear sacroiliac joint, a black line between the sacrum and the ilium. If you now look across to the right hand diagram, you can see that the sacroiliac joints are very white and fluffy, and the outline of the joint margin is not as clear. That's sacroiliitis. This slide shows you a pathology specimen on the left of a section through the spine, and you can see how the discs are relatively okay. They're quite large in size, but you can see that they've become encased with this wall anteriorly and posteriorly of bone, and it forms what's called a bamboo spine because it looks like a piece of bamboo. And these little layers of bone that I've tried to show you here on the right, these little blue lips, are called syndesmophytes. In osteoarthritis they're called osteophytes, but in ankylosing spondylitis they're called syndesmophytes. This graphic here is to try and summarize the difference between osteoarthritis on the left, which has osteophytes, and ankylosing spondylitis on the right, which has syndesmophytes. And you can see that they kind of grow at 90 degrees to each other. I'll let you read this in your own time, but I've divided the symptoms here into 3 overarching categories. There are problems with the sacroiliac joints commonly, there are problems with the spine commonly, and it's also not unusual to get peripheral joint involvement, so a shoulder or a knee or a hand or an ankle even. Again, just have a look at this graphic. One of the key pathological indicators for ankylosing spondylitis is what's known as an enthesopathy. The enthesis is the name for the part of the body where a ligament or a tendon inserts to a bone. And what happens in AS is that you get an area of reactive bone inflammation. The ligament or the tendon becomes partially detached. You get a bump of bone that forms, and then the ligament or the tendon reattaches at a future date, and that's extremely painful. There is a very strong association between Hla B27 and ankylosing spondylitis, but don't forget that it is possible to have the gene and not the disease, or the disease without the gene, but there is a very strong correlation. So one of the first blood tests that will be done is an Hla B27 test. Try to illustrate here what's known as a bamboo spine. So if you look at the right sided graphic, these are some lumbar vertebrae. You can see how where there should be a gap between the lumbar vertebrae, there's actually a lip of bone that's formed. You can see it on 2 levels here, upper and lower, and you can see how the margin looks like a piece of bamboo. So that's where the term bamboo spine comes from. This is the X-ray of the cervical spine of somebody with advanced ankylosing spondylitis. This is somebody looking towards the right, so you can see the jaw you can see the cervical spine, and you can see the top of the shoulder girdle. If you look at the base of the cervical spine, you can see that the lower 4 vertebrae are all fused into one, and then there is still some movement higher up. Worst case scenario with the AS is that you can get severe postural deformities which become known as a question mark deformity, and I've shown you here why it's called a question mark deformity, because this gentleman's spine has taken on the shape of a question mark. So you can see, going from lower to upper, he has knee flexion contractures, he has hip flexion contractures, he has a flattened lumbar spine which has the effect of pushing his abdominal contents forward, which gives him the appearance of kind of a beer belly, because that's actually his abdominal contents being pushed forward. He's got a very exaggerated thoracic kyphosis. His cervical spine is virtually horizontal, and because of that he has to hyperextend his upper cervical spine so that he can see where he's going. So you'll learn about center of gravities and line of gravity. You can see with this gentleman that he's inherently going to be unstable. He's going to be falling forwards all the time because his line of gravity is in front of his base of support. So that in itself is going to be extremely tiring. Enthesopathy can happen anywhere, but it's very common in the shoulders and the hips and the knees. It can happen in the elbows or the wrist. It can also happen where the joints of the ribs are and where the cartilages of the ribs join together, and that can be very distressing because the patient thinks they're having a heart attack because they start getting chest pains. It's also possible to get pains around the greater trochanter, around the areas of, for example, the attachment of the medial or lateral ligaments in the knee, the Achilles tendon, or plantar fasciitis. So just keep an eye open. It's not unusual to get a young, usually male patient with back pain if they also start to complain randomly of aches and pains, for example in the Achilles tendon or plantar fasciitis, or they also have a history of bowel problems or eye inflammation. What might appear to be very disparate symptoms may actually all be part of the same syndrome. Just for interest really, I've added this slide just to go through some of the incidences of this Hla B27 and what the gene is actually associated with in pathological terms. Because this is largely a genetically related condition, it also has major geographical variations because of allele frequency differences in the population. So you can see here that it's relatively common in North America, but relatively unusual in Africa, for example. Thought it was worth describing what ankylosing spondylitis can do to a spine. So in a normal spine we have 3 curves. We have a cervical, a thoracic and a lumbar curve, and they normally balance on top of each other. When a baby's born it has one curve, and then when it starts to look around and take an interest in the world, secondary spinal curves develop. Ankylosing spondylitis can severely affect these spinal curves. And if you think back to the photograph that I showed you earlier of the gentleman with the question mark deformity, figure 1 here is a normal posture. Figure 2 is what severe ankylosing spondylitis could do to a person. So again you can see this flattening of the lumbar spine, an increased thoracic kyphosis, and to compensate so that the person can see where they are going, they have to hyperextend the upper cervical spine and they have to flex the hips and knees. One of the big differences between rheumatology and other MSK conditions is that rheumatology usually has sort of a collagen connection or an autoimmune connection, so it's not unusual to have symptoms that we as physios are perhaps not used to dealing with. So for example, it's quite common for people with ankylosing spondylitis to get a very red inflamed eye, and that's iritis, and that can be very painful, and that can be a medical emergency, and it might need, for example, steroid treatment. There is also an increased risk of cardiac involvement, so people with AS do have a greater likelihood of conduction defects, aortic incompetence, and pericarditis. Pericarditis is inflammation of the membrane, the sac that surrounds the heart. Ankylosing spondylitis can cause physiological changes to the lungs themselves that can cause fibrosis. It's probably commoner for people to complain of pain in the thoracic cage because of the bony changes and the inflammatory changes around the thorax, and that is probably more of an issue, the decreased chest expansion. And one of the things that we may measure in an assessment of a person with AS is thoracic expansion with a tape measure. There is also a link to inflammatory bowel disease, in particular Crohn's disease. Again, in rheumatology, sometimes diagnosis can be difficult. It's very often the case that there is no single silver bullet that will diagnose a condition. So a diagnosis is sometimes incorrect, and sometimes it takes many years to get a diagnosis of AS because it's diagnosed as growing pains or muscle strains or ligament strains or postural problems or whatever. But I've just listed here some of the criteria that are very useful. So we've got the New York criteria and the Rome criteria, and it's a scoring system. If you have so many of the symptoms, you've got definite AS or possible AS. One of the more recent diagnostic criteria is this European Spondyloarthropathy Study Group, or the ESSG, which I've listed here. The management of AS has been revolutionized recently with the introduction of biologic drugs, so hopefully we shouldn't see such severe deformities that I showed you in the slides earlier. But from a physiotherapy point of view or a medical point of view, the aims of treatment are to try and reduce the signs and symptoms, to slow down the disease activity, to therefore decrease disability, to maintain or improve quality of life, and to try and prevent structural damage if possible. You may be surprised when you talk to people who have AS how high level functioning they are. That's partly, I think, because the disease has come on so gradually that they've learned to adapt, and I think also because they know that they need to keep going. So quite often they are able to continue working with quite severe disabilities, really. Probably one of the largest changes in rheumatology in the past 15-20 years has been drug management. What we used to do was start patients on very gentle drugs, aspirin, ibuprofen, naproxen, Voltarol. That didn't work, so we'd get them back in a year or two and increase them to disease-modifying anti-rheumatic drugs that were a little bit stronger. They didn't work. Then we'd try steroids, and then we'd go up the ladder that way. We tend to manage people with rheumatoid arthritis and AS more aggressively now, and that seems to be much more successful. one of the biggest changes are these biologic drugs. They work by mopping up antibodies, so instead of just masking inflammation, they actually do modify the progress of the disease. They are probably quite well established now. They've been going for about 20 years. Initially they were very expensive. They're now off license, so they're a lot cheaper. Not everybody can take them. They are kind of immunosuppressants, so if you have a history of cancer, you might not be able to take them. If you've had TB in the past, it might not be possible to start on biologics. So there are exceptions to that, but if they are given to patients, they can be extremely valuable. One of the things that a patient has to do to qualify for these is to have certain scores on some of the outcome measures that we use for ankylosing spondylitis. And in some of the teaching materials that I will give you, if you have a look at NASS, which is NASS, which used to be the National Ankylosing Spondylitis Society, which is now the National Axial Spondarthropathy Society. Don't forget the name has changed slightly. It's only called AS if you have bony changes. There's some excellent information about drugs for both patients and clinicians and healthcare workers and medics. So there's some very useful information about these drugs and about what can and can't be done with these drugs on the NASS website.